that I want you to read a little bit of historical aspect of some of the bacteria that we have. It's easier for you to remember. And today also I will touch upon an important topic as we speak, which is sexually transmissible diseases, STDs. The other name for that is STIs, sexually transmissible infections. Pretty much the same thing, okay? So this is included as one of the STDs, and I'm going to give you a little bit of historical perspective of that. There's something called National Medical Library, and there are some pictures and figures, the one that I presented the other day about Clostridium, and they keep a record for historical perspective of some of the picture, like this one. I don't know if it's very clear on you or not, but basically it was meant, of course, for the army officers that were deputed out of the country. And this happened to be the National Library of Medicine, and it has this poster that was posted. And apparently you can see from here, they were trying to build this idea in the soldiers that they really have to, as a part of their sense of patriotism, as they're going out to fight for the nation, they also have to make sure that they don't engage in any kind of sexual promiscuity that may bring syphilis home. And that was an issue at that time, and they wanted to control it. And the armed forces came up with this idea: excess. You can't beat the excess if you get venereal disease. So venereal disease is again one of the most famous classical, and they wanted to educate their soldiers, so to speak, that they have to make the right choices. I will appreciate you guys when you finish your attendance sheet, pass it over to me, because I do see a little less attendance today. That's fine. Okay, and at the same time, remember, syphilis was coming. It was in the soldiers, and especially during the World War I, and American soldiers and sailors were counseled to make sure they keep themselves clean, if that makes any sense to you, and abstinent on their furloughs. And they also were told and educated if they ever have to have sex, they were given all these kind of prophylactic kits. So you can imagine at that time, there is no penicillin, and you're trying to educate your soldiers, and a lot of this so-called antidotes or so-called they call like doughboys prophylactic kits were given by the army. Okay, so having said that, I want you to pay attention to this particular case. This is from your book. A 17-year-old girl, she is admitted to the hospital, and she has 4-day history of fever, chills, malaise, sore throat, and polyarthralgia. So polyarthralgia means all the joints are inflamed. So that's serious. When taken sexual history, she was sexually active. And on examination, it was found out that she had a profuse yellowish vaginal discharge, which of course was not treated. The other important thing she had was erythematous maculopapular skin lesion. So maculopapular skin lesion, polyarthralgia, and then she had all her forearm, thigh, ankle, and metacarpophalangeal joints involved. all acutely inflamed. When we looked at her blood report, she had a elevated leukocyte count suggesting infection. Cultures were positive for Neisseria gonorrhea. So you can imagine a gonorrhea, which is a sexual transmissible disease, is presented in this picture. When they took the synovial fluid that was sterile, and they made a diagnosis of disseminated gonorrhea with polyarthritis. The good thing was that this is a recent case, so she was given penicillin G for 2 weeks. But you can see the importance of a careful history. Had they not asked her about being sexually active, or had they not asked for the vaginal discharge, and have they not taken the biopsy, not biopsy, but the swab from her cervix, they would not have found Neisseria. So Neisseria was a culprit in this case. A typical sexually transmittable disease, women, age, and the clinical picture that you can see. So this is how her throat looked like. You can see like a sore throat. She had all the joints inflamed. She had all this kind of infection. When they looked at the cervix, so you can see cervix is inflamed. And they had to take a swab from the cervix to make sure that she grows Neisseria gonorrhea. Now, it's in 1879 when the German bacteriologist Albert Neisser, that's the word coming from Neisseria, he was the first one to discover that. And he was also the first one to discover Mycobacterium leprae as well. So a lot of work had been done in Germany in those late 18th century. If you look at the larger family, there are 10 species found in humans. We are going to discuss today only 2, Neisseria gonorrhea, Neisseria meningitis. And again, as the name suggests, it's going to cause meningitis. They are strictly human pathogens. So this means that they are human pathogens. Okay? The remaining species of 8 are commonly present on mucosal surfaces of oropharynx, nasopharynx, and can colonize anogenital mucous membrane. So they have a liking for mucous membrane. Diseases are well known, and we pretty much know that they can also occur, as I just told you, especially Neisseria gonorrhea, as sexual transmissible disease. As far as their biology is concerned, they are gram-negative. So they are gram-negative. They appear as diplococci. They grow at our body temperature. You can see from here. They are oxidase and catalase positive, and they produce acid from glucose. They have a lot of antigens because you can see from here, they cause a lot of damage. All joints are involved, all mucous membrane are involved, and some of the toxins, antigens are pili protein and other proteins, transferrin, lactoferrin, hemoglobin. You can see they have tons of antigens expressed on the surface. So we may have a very robust immune response. Okay? If you were to look, bring it over to me. I hope you haven't, nobody has signed for anybody else. Is that correct? So where's Mercy? Who's Mercy? Okay. Who is Gifty? Gabriel. Crystal. Sandeep. Jesse. Somebody signed for Jesse. Signed and left? What do you mean? Went to the bathroom. Okay, all right. Okay. Tanaya. Benjamin. Bakizi. Ryan. Ruslan, Tesfaye, Zachary, Julian, Nora, Wing, Lilian, right? If I pronounce it right, Lilian, Angelo, Benin, Lee Hunley, Basma. It's about my time to start looking at your Facebooks. Emily, Emily, Han, Chinonso, right? Jessica, Elaine, Eric, Anne, Victoria, Andre, Zillehuma, Huria, Alan, Nishant Shah, Veronica, Renisha, Heather, Anne Tran, Peter Wang, Amber Wright. Did I miss someone? You didn't sign? You signed it?
Yeah.
So why did I miss you? What's your name?
Claudia.
Last name?
Bronx.
There's one person we're waiting to come back from bathroom, right? That's what you told me? Yeah? Did he go bathroom with his bag and everything? Okay. All right. All right. So this is how it looks like Neisseria diplococci. You can see they occur like in pairs. And if you do a gram staining, you can see from here typically structures. When I say diplococci, they kind of come in pairs. That's what you see. And many different pictures of that. This is a urethral exudate. Neisseria gonorrhea, spatial arrangement, pairs of cocci. You can see it comes together. And if you look at their other characteristics, as you remember, I said that you have to compare one with another. So they are gram negative. They are non-mortal. So that's important. They cannot possibly move and do not form endospores. All species are oxidate positive, and mostly they produce catalase. And remember, catalase are required for them to cause skin damage. They produce acid, and they oxidize carbohydrate, right? But the process is not fermentation. So what we normally do is that this is how we make a test. If you want to compare between two strains of Neisseria, you can see both of them are acid positive, but this one will just produce acid with maltose, with maltose and without maltose. So you can see we can differentiate. We can do this test to find out that their pattern of carbohydrate utilization to differentiate. If I was to ask you, how would you differentiate if the person is suffering from gonorrhea or meningitis, the answer is that the pattern of carbohydrate utilization, this will make acid with maltose and this would not. So that's a diagnostic test for comparison. Okay. Pathogenesis. As you saw, they attach to mucosal cells. They penetrate and they divide. And for attachment, for them to stick on, that's another important concept that I'll teach you when I teach you in detail sexual transmissible diseases, is that Most of the bacteria that attach to the mucous membrane have these proteins like PIL-4B and opoprotein. They not only mediate attachment, but penetration into host cells. So no matter if you wash before or after having sex, it's not going to help you much, because the thing is this, these bacteria have very strong attachment. So once they get into you, they're going to stick there and will penetrate. Once they do, they have, remember we talked about a very potent stimulator of immune system. Does anybody remember what did I say about the most potent stimulator of immune system? LPS, very good. Who said so? Very good. LPS. So lipopolysaccharide. So the same way there is a lipo-oligosaccharide. So make sure that you differentiate between that. There's one lipopolysaccharide, LPS, very strong stimulator of immune system. Lipo-oligosaccharide. It also stimulates pro-inflammatory cytokines. And then again, this is the culprit for the general symptoms of disease that we see, especially tumor necrosis factor. Now, if you look at the bunch of the virulence factor for gonorrhea is, so that will also pose a challenge that why do people have STD? I mean, you can get STD just by one exposure. We'll talk about the incidence of sexual transmissible diseases in terms of number of partners, in terms of number of sexual encounters, so on and so forth. But by far, if the virulence mechanism is like this, you will get an STD after a single exposure. So you can see each one of the virulence factors has a role to play. For example, some of them are there for attachment. Some of them are there to promote intracellular survival. Some of them are there to stop phagosome-lysosome fusion. And some of them have very specific roles in terms of attachment and penetration. And especially for Neisseria gonorrhea, you need to concentrate that how does bacteria divide. So once they go into the system, they start division, and they use iron. So you can see they use your iron. It will suggest to you they're going to deplete you of iron, because they need to consume your iron to grow. So you will have depletion of iron in this case, right? And then again, lipopolysaccharide is also a part of endotoxin, but lipo-oligosaccharide, again, has endotoxin activity. And then again, it produces IgA protease that destroys immunoglobulin A, right? The chances are that IgA is protective on your mucosal surfaces, so they chew them up and increase the chance of infection. And then again, they have a beta-lactamase. So all of you have done the first lab. We talked about the roles of beta-lactamases, okay? And you can see that the function of that enzyme is to hydrolyze the beta-lactam ring in penicillin. Now, we are concerned in terms of epidemiology. Epidemiology will remain as one of the most important subject as we speak. They are only present in humans, and I'm going to talk about those questions that I may ask you, and then you can figure out, where these questions coming from. The problems for epidemiology is that women can carry this organism and be asymptomatic. So if they are asymptomatic, they would never go for treatment. So they can be asymptomatic and pass it on to other people. That's why you saw in the initial slide for the army was trying to kind of impose upon their soldier is that, you may have the weird ideas of cleanliness, but the thing is that if a person even is not having an STD or STI and she seems to be clean, she may carry it, and she's going to pass it on to you, because they are asymptomatic carriers as compared to males. Transmission is primarily for sexual contact. That's why it's called STD. Okay, and then again, a very high incidence in the United States. This is all statistics in the book. I didn't go and change it, but I may show you in the end. I do have some latest, but it is very high in terms of STD. If you look at the proportion in US, it's very common in blacks, very common in this 15 to 24 age. is usually common in southeastern United States. I don't know whether it has an impact on people having sexual activity, but that's what they say. It's going to be very high for those people who have multiple sexual encounters. It's not as a partner, it's like you increase the chance of getting infected, and especially for those people who are visiting prostitutes. So that's a very high incidence of people getting STDs. And also higher risk in patients who have deficiency in late components of complement. So you see this question I asked when is there in complement as well. So that's important in terms of epidemiology is concerned. Now, this is pretty much the repeat slide. You can read it on your own. Let me see if I can bring up. Okay. I think the graphs are coming later. But that was just a repeat of one of the things I said. So very important of asymptomatic carriage in women than men. Okay. The other important thing that you have to see is that the moment men get it, they become symptomatic. So what will happen is they go for treatment. And then women, when they get it or they pass it on to their partners, they're asymptomatic, they keep on infecting other people without getting problems. So that's a serious concern in terms of STD. The symptoms should clear, even if it's untreated, depends upon your immune response, but you have a asymptomatic carriage. So you will carry that. You will carry that. I'll talk about the statistics of STDs and incidences and so on and so forth. That's why in most of the countries, even they give a license to sex workers, and they want to make sure that they test for certain bacteria, and then people who go and visit them, they can take their own chances. But the chances are that people who go and acquire these kind of STDs, they can acquire STDs by any sexual preference they have, whether they're going to go for any route of having sexual encounter, whether it be oral, rectal, pharyngeal, and whatnot. So people may have different preferences, but the thing is that the bacteria is going to go into the system regardless. Okay. Now, this is an older slide, but it gives the burden that if CDC or NIH to deal with STD, they want to open STD clinics. So these are some of the common STDs that we have in US. And the incidence varies generally, but you can see if I was to ask you which one is the #1 STD in the United States, is chlamydia, gonorrhea, syphilis, trichomoniasis, human simplex virus, and then papillomavirus, right? Herpes simplex virus, papillomavirus, hepatitis B, and HIV. So 1, 2, 3, 6, and 8, and there are a couple of more. So these are 10 lists in terms of incidences that we have. And you can see in terms, incidence means that reported cases that these people have reported. But also remember, not everybody reports to the STD clinic, and especially women. They would not report, and the reason is, what's the reason they would not report? What's the reason the women would not report? I just told you. Asymptomatic. Why should they? It's asymptomatic. Who cares? Is that the point? So that's important. And then again, in terms of prevalence, is that you can imagine we have a population of 300 million. In 1996, 20 million were estimated to be positive prevalence, but not, right now the CDC thinks 99% of the population is having HPV, even in a straight relationship. So it's not like in a particular group who are promiscuous or who are visiting such and such places, very common. So HPV is going to become a big challenge for us in future, but these numbers keep on changing, but nevertheless, they are on the rise. If you were to look at men versus women in terms of the age group, of course, people are sexually active from 15 to 24, very high incidence, but the proportionate is more in women as compared to men. Okay, and the incident declines because of the age, but the total incidence is, I would say, more in women as compared to men when it comes to rates per 100,000 of the population. So women have more gonorrhea as compared to men, especially age from 15 to 29 or later. If you look at the rates in terms of age over years, and I would want you, those of you who are doing these topics, to please, for the benefit of rest of the class as well, get the new CDC statistics, right? The chances are it's going to be a little bit more. So if you have it, who's got topic on Neisseria gonorrhea? Anyone sitting here? So make sure that we see the new CDC statistics, okay? So you can see from here, it's pretty high age-wise, but over years, for last 10 years, it's still there. With all this education, school education and condom and so, or sexual behavior and whatever you're talking about, everywhere, by the end of the day, ages 15 to 24 are not listening. And you are older than that, I believe so, okay? So the thing is this, that it's a very serious concern as far as STD is concerned. And we'll talk about that. Many of them, most of them even don't care. If you look at in terms of men, previous one was women, again, you will see that age group pretty much the same, those people who are sexually active. That's why I used to say what's the best treatment for not getting STD? Huh? Total abstinence. That's what it is, unfortunately. It's not abstinence alone. If you look at the race, and that is totally out of control, as you can see. Over here on the top is a Black population as compared to any other population. So you can see very high in terms of multiplicative problems, especially in women. And it's a little bit less over here, but still by all standards, static in other groups as compared to this particular group that the CDC thinks needs to care about. Okay. And these are like, I mean, if you're not familiar, I thought you are ahead of the game. So this means, like for example, if I can see it very carefully, come closer. So 800 cases of STD out of 100,000 population. So what it means is 1 in 10 of the Black population will have gonorrhea. That's what it means. Okay. Now, if you look at in terms of percentage of reported cases by sex in terms of men and women, you can see that they go and see the hospital. There is a lot of issues with that as well, because people may not be having the access to healthcare and so on and so forth. But reporting is a challenge. So what they think is that it's a tip of iceberg. So if I tell you 1 in 10, that may not be true, because I'm talking about reportable cases. So they think it should be even higher than that, because people firstly don't disclose, they don't report. Okay, so the problem that we are having is, especially in this country, is that they think there's an epidemic that is underappreciated and is hidden from public discourse. So they think it is a hidden epidemic out there because of the cultural or health. There are a lot of factors there. So it's not only acquiring of infection. That's why when we go for therapy, we go for therapy for not only medicine, but we go behavioral therapy, because it's something to do with the psychology as well. A typical presentation in the STD clinic. Did anybody work in STD clinic? Okay, I had a couple of students working in STD clinic. You may be asked to work in STD clinic, and the typical presentation, and people will go to STD clinic, is that they go because of the drips. That's what they call it, a drips. That's a typical sign for not only public education, and maybe, I mean, this may be a repeat information for many of you who have had that lecture as a part of high school STD or any other school. I'm pretty sure, because I'm going to use standardized slides, so they're pretty much from CDC, borrowed from CDC, and they should be repetitive, I guess. So if a person presents with drips, the chances are you may have gonorrhea, or you may have non-gonococcal urethritis. Urethritis means inflammation of your urethra. Chlamydia, mucopurulent cervicitis, trichomonas, and candidiasis. So this is a challenge. The other important thing is that if a person has that kind of a behavioral kind of problem where he's involved into that behavior, so he would not have one STD. That's another thing for STD. When a person walks into STD clinic, they test them for all STDs. Because if you're going to go for that sexual encounter, you will pick up more than one. Right? So that's also important, that they don't test you for only one, they test you for more. For Neisseria gonorrhea, again, the typical presentation is that they present as a pus coming from their urethra, cervix, epididymis, prostate, anus, and it has an incubation period of 2 to 5 days. So that's the very first thing people notice, drips. That's what we call pus coming up out of the urethra. As you saw in the case, it was disseminated infection where whole skin was involved, whole joints were involved, whole inflamed sores. So you see skin and joint involvement. And if you look at their joints, they are suppurative, pus forming, having arthritis. And if a woman has STD and she plans to deliver a baby, so the problem is the neonate may get infection, we call ophthalmia neonatorium, from an infected vaginal canal. So if they decide to have a vaginal delivery, so it may be an indication for a C-section if a mother happens to have an STD. As far as clinical manifestation is concerned, typical symptom that will bring a male into STD clinic is pus coming from urethra. So you'll have a urethritis, and again, he would have, dysuria, mean pain while urinating. You'll have urethral discharge. 5% is asymptomatic, but that's not large in terms of female. You just take the smear and you do gram staining C and you see diplocoxide. What brings female to the clinic is that they have urogenital infection. And they can have endocervical canal as a primary site. And then again, it's going to stay for some time, and they may be asymptomatic or at the best show a vaginal discharge. They may have dysuria. They may have a problem in urination. They have labial pain, swelling, abdominal pain, so on and so forth. And they may get complications because of the proximity of the genital canal through urethra. So it's like, a complicated matter. Typical presentation, pus coming from urethra, CDC educational slide, and you can see from here, if you were to visit the patient may take as normal semen, but that cannot be normal semen. The differential diagnosis that you usually tell to the medical student is, I'm going to ask you, burden you for that, because the meatus, the opening is inflamed, is red as compared to a normal thing. There could be non-gonococcal urethritis. So you can see from here, the difference in this case is that if you were to examine this patient, the meatus, the opening of urethra, is not inflamed. So there is something called non-gonococcal urethritis. In this case, that may happen. Again, this is from the educational slide. So when we say non-gonococcal urethritis, we are talking about other chances in terms of chlamydia trachomatis. So I'm going to ask you, what are the causes of non-gonococcal urethritis? And I'm going to say over here, Chlamydia trachomatis, mycoplasma, and some unknown causes like trichomonas. And these people present with mild dysuria, mucoid discharge, and if you look at their smear, they'll see a lot of neutrophils over there. Okay, now I just discussed that male may consider that as a semen. It's not semen. A discharge may be colored because of infection, and this usually brings male into the clinic because of the pain associated while they urinate. They also can have skin lesions, as I said earlier. That's a immune response to the infection, because if your whole immune response sets in, you may have a problem. If that mother gives birth to a baby per vaginum, so baby may have infection of the eyes. That's what shows is called gonococcal ophthalmia neonatal. So the poor baby would have lid edema, erythema, and pus coming from the eyes. This is an advanced case of skin lesion when meningococci, which is another Neisseria, it goes into the blood. Yeah, I just put it over there to tell you that it's very nasty in terms of immune response. In STD clinic, I think I always think to give you that lecture first about the normal commensal, but I'm going to repeat over and over again. You better go and look at what are the normal residents at different openings: eyes, ears, mouth, armpits, vagina, urethra, so on and so forth. So you pretty much know what is normal and what is abnormal. Now, it should not appear. If you look at, for example, a girl, maybe I'll say less than 10 years, in this case, she may have a different normal vaginal flora. And all of a sudden, if you see Neisseria, gonorrhea, which should not be there, the chances are that this is a case of incest. How do you diagnose? You look at the gram staining of the specimen. You do culture. You can do nucleic acid amplification assays. That's normally done in most laboratories, in terms of finding out the culprit, exactly if it's going to infect more than one person. Now, if you look at the statistics in terms of Neisseria, you can see from here, it can cause an infection anywhere from the heart to different parts. It sits over there in the joints. It sits over there in urogenital region. That's why it's called sexually transmissible diseases. And then it can spread to any part of the body. And they're all presentation depending upon the skin. But I gave you a classical case where there was a young girl, sexually active, vaginitis, polyarthralgia, skin. That's a typical case that you cannot miss. And if you take history, she will tell you. Ceftriaxone is the current treatment of choice. And if it's complicated by chlamydia, I just told you that you don't have one STD, you may have more than one. So you have to treat all of them then, right? So chlamydia, which is number one in this country, you have to use doxycycline, erythromycin. If it's neonates, you have to use 1% silver nitrate. How do you prevent? And we'll have a big discussion on that and STD. Part of the prevention is awareness. Part of the prevention is discouraging people to go for that kind of a behavior that will put them at high risk. But again, anywhere from using condom to spermicide. But the problem in this case, as you can see, is that we normally treat patient. But in STD, we don't treat patient only. We treat the partners as well, right? But that's another problem. Because if you take in history, a young 16-year-old girl walks into your clinic and you say, where are your partners? How many are your partners? Nobody's going to show up. So there is a lot of issues with there because of the, what do you call, a confidentiality issue over there. Okay? And that exposes person as well. But that's the challenge that we have in terms of treating sexual partners as well. Unfortunately, there's no effective vaccine, so there's no license for you to have a vaccine and do whatever you want to do. So be careful. Okay. Let's jump to the second Neisseria, which is meningitis, as the name suggests, that it is, again, a gram-negative diplococci. Grows best at our body temperature, is again oxidant catalyst positive. It produces acid, both from glucose and maltose. Remember, we talked about, I just gave you an example for maltose, but also for glucose as well. It has all those polysaccharides, lipooligosaccharide. It has a capsule that protects from antibody-mediated phagocytosis. And then again, in this case, bacteria survives because intracellular killing, because there's no humoral immunity. Humoral immunity means antibodies. Most of the problem that we see in this case is endotoxin, which is coming from lipooligosaccharide. It's not endotoxin per se, but it has endotoxin-like activity. So it's going to create a robust response. If you do a gram staining, this is how it looks like. You see diplococci. They are important. Okay. I don't know, I'm going to do that for your class as well, because in last couple of years, we had some of the questions showing you this slide and say, identify the bacteria. And this is a diplococci, so it has to be Neisseria. If you look at the features for this particular bacteria, as the name suggests, it's going to cause meningitis, which is inflammation of meninges with all the associated symptoms. If it goes to meningococcemia, this means blood. It goes into the blood. So it will go wherever the blood will take it. I gave you one picture for the skin lesion, very difficult to treat skin lesion. It can also cause pneumonia. So you can see a milder form of meningococcal pneumonia. The major culprit for pneumonia is Streptococcus pneumococci, as compared to, because it may look similar to you. So people will get confused with Streptococci pneumoniae from Neisseria meningitis causing pneumonia. So they're all different. Again, they are naturally present in human. Person-to-person contact is aerosol, so it's not a STD. So it is not a sexual transmissible disease. The highest incidence is in children, especially younger. And we have meningitis, especially from these strains. And especially, as I said earlier, they want to make sure that they serotype a particular strain, especially if there's school outbreak, and you want to make sure that 10 kids have a same infection, so you can trace the infection and get a serotype. They also do it under WHO worldwide as well. Disease is worldwide, but commonly occurs in dry and cold months of the year. If you want to look at their gram staining, it's going to be a gram staining cerebrospinal fluid, right? Is of limited value for blood specimen. And then what they normally do is that if you got meningitis, you do spinal tap, right, and look for bacteria over there. But the best way to do is culture definitive. And then there are some tests to detect meningococcal antigens, which are insensitive and maybe non-specific. How do you treat, prevent? Typical slide that we normally see. Breastfed infants have passive immunity for the 6 months. Why? Huh? Correct. That's something to do with the breastfeeding. Correct. IgA will be there anyway. IgA is not a big deal. IgA should be there on the mucous membrane over there. But these are some of the antibodies. They are transferred as protective antibodies. You can also give chemoprophylaxis for people who are in contact. For immunoprophylaxis, we can also add vaccination for certain strains. But you can see from here, when things are have a capsule and there are a lot of polysaccharide, some of particular strains may not have an effective vaccine. So that's what we remember. I talked about a polyvalent vaccine that you basically shoot for more than one marker over there. Okay. So I'll stop here and take question